Welcome to the Department of Defense's Cancer Community Conversation for the Biden White House Cancer Moonshot. Thank you for joining us. It's my privilege to introduce Ms. Shalene Mullen. She's the Principal Deputy Assistant Secretary of Defense for Health Affairs. She'll be leading today's session. I'm Craig Schreiber, Director of the Martha Cancer Center and Professor at Uniformed Services University. And I'd like to invite our participants to now introduce themselves.
Good afternoon, everyone. I'm Captain Oksana Reed. I'm a stage 4 breast cancer patient.
Good afternoon, Lieutenant Colonel Eric Miller. I am in full remission from stage 1 Bravo endometrial cancer and multiple basal cell carcinoma.
Good afternoon. I'm Manuel de la Cruz. I'm was captain in the Marine Corps from 2015 to 2023. I'm a testicular cancer survivor.
Hello, my name is Shante Drincourt. I am an Army spouse, also a nurse practitioner. I have been living with stage 4 metastatic breast cancer.
Good afternoon. I'm Staff Sergeant Brian Ernst. I just actually recently completed treatment for classical Hodgkin's lymphoma.
Marie?
Hello, I'm Marie Borsellino. I'm an RN. I'm the Cancer Survivorship Coordinator at the Martha Cancer Center.
Hello, my name is María Fernandez Rivera. I am the Young Adult Patient Navigator representing the Allman Foundation in connection to the Martha Cancer Center.
I'm Sarah Bernstein. I'm the Deputy Director for Martha's for Palliative Care and Survivorship.
Ma'am, thank you for being here and for hosting this session. And I invite you today for the wake up.
All right. First off, thank you very much for the invitation to join this conversation. I always welcome any opportunity to come up to the Martha Cancer Center, which is the only DoD Cancer Center of Excellence in the military health system, and it is recognized nationally for its superlative patient-centered care. The military health system is proud of the Cancer Moonshot effort, recognize that cancer touches everyone in some way, as a patient, a family member, a caregiver. Addressing issues of survivorship is increasingly important as advances in research and treatment have led to greater survivorship rates for cancer patients. The National Cancer Institute estimates that there are more than 18 million cancer survivors in the United States, about 5% of the population, and that number is expected to grow to 22.5 million by 2032. Support for our cancer patients, survivors is critical. Once treatment ends, many survivors are left feeling uncertain and on their own. Here at Martha, there is a multifaceted program of post-cancer support for survivors and family members, a model for the rest of the country. This kind of support is important for all survivors, but especially those diagnosed at young ages, which is often our population, with who have very long lives ahead. I also want to recognize the role of caregivers, both the healthcare teams and the loved ones of patients. Part of our responsibilities to take care of people is recognizing the impact of healthcare professionals who choose cancer care and providing support and resources for them. Support to the family and friends who are caregivers is also important. The military culture is one of comradeship and where we look out for each other. And there's a system and strength in ours, but the role of cancer caregivers is in a category all by itself. Caregiving has complex impacts on both patients and caregivers and their relationships. Support networks play a critical role in many ways. Information sharing, emotion support, and investment. I know we will discuss these issues and more in today's community conversation, and I thank all of you for taking the time to be here and join the dialogue. I'm now interested in hearing each of your stories. So, Sonia, you want to start?
Yes, you. Good afternoon, everyone. I'm Captain Oksana Reed. I have incurable stage 4 breast cancer. I was diagnosed at age 24 with stage 2. For today's discussion, I've narrowed my experience down to 2 main areas of improvement. My statement is based on my experiences and is my opinion. First, the Department of Defense can better support military cancer patients by improving access to cancer screenings. My stage 4 incurable cancer diagnosis was likely preventable had I had a higher quality primary care provider and if I had received a cancer screening sooner. When I first told a PCN about my breast lump and family history of breast cancer, she did not perform a breast exam. Instead, she replied, "You're 24, you're at your peak reproductive age. It's normal to have lumps and lumps in your breasts." Trusting my PCN turned out to be the most damaging decision I've ever made. Not only did she fail to assure the standard of care by not performing a breast exam, she omitted information about the breast lump in her notes from that appointment. For 8 months, I watched the lump triple in size until I was finally diagnosed with breast cancer. From when I finally received a breast ultrasound referral from a women's health specialist, it took 14 weeks to get that breast ultrasound. After being turned away by every radiology clinic in the National Capital Region over the phone, I walked into the Joint Base Andrews Radiology Clinic. They had a sign on the front desk advertising walk-in mammograms, but they turned me away after explaining they only perform mammos of women aged 40 or older, regardless of whether a patient had a referral. Andrews Radiology directed me to one of the 2 military breast centers. This was the first time I had ever heard about a breast center. I felt the groaning and painful lump on my chest was finally going to get warranted attention, but I once again faced a delay. The Walter Reed Breast Imaging Center is offering an appointment 9 weeks later, nothing earlier. I examined the scheduler about my referral and groaning lump, but she firmly stated it was their first available appointment. Most civilian breast centers strive to schedule imaging for suspicious lumps no longer than 3 weeks out. Though I figured this was better than nothing, as the Fort Belvoir Breast Center was unreachable. Their voicemail stated they were not monitoring phones due to a manning shortage. It was during that appointment, 8 months after I told my PCR about the lump, that I was diagnosed with breast cancer. Until the day that I die, I will wonder what my life would have been like if I didn't face those delays. My story is not unique. The pushback active patients face when trying to get screening lab work or imaging is unacceptable, especially considering that many military jobs expose members to carcinogens and explosives, jet fuel, PFAS, and burn pits. We deserve better trained PCMs, providers who take the patient seriously and shorter appointment wait times for cancer screenings. Second, the Murtha Cancer Center can improve patient outcomes by increasing surgery options for community breast cancer patients. Prior to my mastectomy, my assigned military surgeon told me that the military does not currently employ breast fellowship-trained surgeons, yet I knew at civilian facilities nearly all mastectomies are performed by breast-specialized surgeons. After receiving an opinion from a breast surgeon at Johns Hopkins, I told my assigned surgeon at Walter Reed that it did not feel comfortable proceeding with mastectomy with a military surgeon for that reason. He informed me that TRICARE would almost certainly deny referral to a sibling facility because I'm active duty and the service is technically available at Walter Reed. Though today, Dr. Schreiber informed me that the Murtha Cancer Center does indeed have breast fellowship graduated surgeons. Yet, I was told the opposite when I specifically requested one. The breast reconstructive services at Walter Reed are also inferior to those available in the civilian sector. I was not informed that the military plastic surgeon who performed my first stage breast reconstruction was not board certified in plastic surgery at the time of my case. Civilian patients pick their plastic surgeon after reading on-field reviews and seeing before and after photos. Military patients go in blindly as neither reviews nor before and after photos are readily available to us. The option to safely spare my nipple was also unavailable. A microsurgeon who usually assisted on nipple-sparing mastectomy cases was deployed. Even this limitation did not open the option to have my surgery at a civilian facility. When I expressed concerns about these inequities to my surgeons, they both explained to me that military surgeons are trained to match the military mission set. Surgeons must maintain the skills needed in deployed environments, primarily general surgery and trauma skills. The general and plastic surgeons at Walter Reed can have much more varied caseloads. When I get out of pocket to consult with local civilian breast reconstructive plastic surgeons, I struggled to find one that accepted TRICARE. The Women's Health and Cancer Rights Act of 1998 does not protect active duty military members. This is a policy change that is long overdue. TRICARE's payout is too low for civilian reconstructive surgeons to cover the cost of most procedures, namely deep flaps. Active duty members are legally required to hold TRICARE as their primary insurer, barring us from the nation's most skilled breast and reconstructive surgeons. Being in the military should not restrict our access to the nation's best providers. I would be remiss not to highlight the people at Walter Reed who help us navigate these frustrations. The Murtha Cancer Center's embedded social workers are absolutely critical to patients and caregivers. Walter Reed psychologists and psychiatrists work seamlessly with the Department of Social Work. Organizations like the Ulman Foundation and the Henry M. Jackson Foundation provide patients and families with resources and provide the hospital with exceptional employees, such as case managers and social workers like Mary Bellis. Still, we deserve better access to quality and timely care and better insurance options. Thank you.
Okay, man. So, I'll say this, that COVID saved my life. And the reason COVID saved my life is because the first time in my almost 20-year career, I decided to fight to go to a doctor. I knew based on the period I was having every month being a huge change. It wasn't just hormonal changes. It was very different. I called TRICARE to get an appointment at the OBGYN clinic at JVLM, and I was told, no, you have to go to your primary care doctor. I told them I didn't want to go to my primary care doctor. That same primary care doctor I sit across from in every single meeting of a town bell at brain. That I wasn't prepared for them to have such a private examination and then the next meeting go into talking about the readiness of the organization or how we were going to do a deployment to Japan and what medical requirements they were going to meet. I told them I wasn't comfortable, and their response was, they're trained to do that, and that's who you need to go to before he can get referred to the Women's Health Clinic at JPL. Luckily, because of COVID, they were accepting any appointment. And so I went in there, and I will always thank that captain that was in there, and she listened. She listened to what I had to say. She did not blow me off. And she actually performed I learned the difference between a cervical biopsy and a uterine biopsy that I had no idea was the difference. And it saved my life because I came down with endometrial cancer. But that's just when the frustration started. I will tell you, I had phenomenal health care at JVLM. However, I did not have a case manager. It was all up to me to navigate the road by myself. I'm also a single soldier. So my Army family is great, but my Army family is not going to help me when I need to get to the bathrooms. They're not going to help me when I need to go take a shower. And there's no help to figure out who was going to come help do this. I was very lucky, and I'm blessed with my family and my friends. I did not have to worry. They created a plan to cover the state. But that's not where the biggest fight happened. The biggest fight happens when you work at your military personnel policy level. Healthcare can say that you need to be on a profile. Healthcare can say you don't need to take the ACFT. However, your commander can override that. Your commanders can guilt you into everything. At the same time, I was selected for Lieutenant Colonel, and I was also selected to compete for command. To compete for command, I had to send a waiver all the way up to the Chief of Staff of the Army because I couldn't take the ACFT because I had cancer. 3 days before my cancer treatment, I was called and asked to push that surgery so I could go to that command board. I had some very curt word to them, and I was very blessed that I had supervisors in the middle that took this on. But the highlight was that my uterus and my inability now to have children was talked to at a highest level of leadership in the Army. And I felt violated. I still feel violated. It's sensitive when you start talking about it. I was dealing with not being able to have children of my own. Dealing with I didn't know what was going to happen, what stage I was. And yet, still wanted to be right. I was questioned on why I wasn't taking an ACFT. 6 weeks after my surgery, I had to get a height and weight done. No one had seen my scars. Yet I had 2 soldiers that had to do my physical TB to make sure that I was under those standards because we don't have an exemption to height and weight in the Army or the DOE unless you're pregnant. The other thing is the standard of care. We talked about, I specifically talked a little bit about the problem when you're a single soldier, but it's also hard when it does not feel like there's a standard of care. So it's really on the soldier, on the individual to figure out what's happening at Walter Reed is different than it was at JBLM. Even at Walter Reed, I will tell you, OBGYN oncology, I cannot speak highly enough to them. Every time one of my appointments, I have a spreadsheet or a little piece of paper that tells me every clinic I need to go to, gives me my phone numbers for everybody and my referrals. I went to dermatology and had biopsies done and had cancer, was given topical chemo and was like, okay, that's it. I didn't know what I was supposed to do next. Do I have follow-up? Do I come back? Do I use it till it's complete? I had no idea what I was doing. And it's the same, literally just doors down from each other. Also, if I have one more doctor tell me that I have the best type of cancer I could have, I may lose it on them. Because I want to know, I've had multiple types now. So do you want to fight it out? Like, how do we judge that? It's also on the soldier to figure everything out. So I need to have pelvic floor therapy. I understand I need a very complicated one, and one that is lots of people need to have. I know at one point there was only one therapist at Walter Reed to growing up to 3. But so I'm sitting off post. So go to the TRICARE website. Can't choose pelvic floor therapy. You can only choose physical therapy. So then I had to go into Google and look up every individual location to see. And I will tell you, the ones with the best reviews didn't take TRICARE. And so what I ended up doing was not going to take the pelvic floor therapy, which is now for me, and I'm not doing that. And so that also makes it very complicated. I think that that's the hardest part, is with the policy point. It's great that you're here, ma'am, but the fact that there's no one here from personnel policy is a problem. Because you guys can do like all this great policy, but if the command policy and the personnel policy doesn't change with it.
We can talk, I don't want to interrupt your story, but we can certainly have a conversation about how we can sort of address some of these concerns.
And the last thing I want to talk about insurance is that we don't have healthcare savings accounts. So I get to pay for Goop sunscreen on my own, glasses on my own. And this is something that it can be a financial hardship. Obviously it's not for me because I'm, it's lucky to have that. But there are a lot of other soldiers that don't have that flexibility. And that is something that we could do. It could also help us to that. Thank you.
Good afternoon. Like I mentioned before, my name is Captain Manuel de la Cruz. And as I share my cancer journey, I want to highlight the challenges my family and I overcame and some of the insights that I've gathered on how the DoD can better improve and support service members as they navigate their diagnoses and treatment. Now, I'm grateful for this opportunity to speak in this forum, as there's much to improve in the DoD's processes, policies, and just the overall system to support active duty service members. In 2015, I had my commission as a Marine officer. I served on active duty until 2023 in October. And during this time, I was diagnosed with testis cancer in January of 22. This is when everything changed. I underwent 3 surgeries, 2 bouts of recurrence, 4 rounds of chemotherapy, and 5 other procedures over an 18-month time period. Just a few months into my course of treatment, my primary care team took it upon themselves to refer my case to the disability evaluation system. I made a mistake in trusting my primary care provider. The uncertainty and the lack of transparency with the system ended up causing even more stress and challenges than the cancer diagnosis alone. More challenges. Over the 2.5 years since my diagnosis, I overcame much. And some of these challenges have been directly caused by the DoD healthcare system. And for others, we saw significant relief through existing programs available through the Northern Cancer Center. The resource that provided the most relief was the mental health support programs. So that's one of my first points to sustain is the existing mental health support programs and the amazing clinical social work team at the Northern Cancer Center. A simple introduction or a forum to connect with other caregivers and patients navigating their own journey was extremely helpful. There was, numerous support groups and just talking to somebody else that, like Brian, Oksana, Erica, that just get it, that makes a big difference. Anybody can try to relate to a cancer patient, but you don't get it until you actually had it. One issue with this, however, was eliminating, the military stigma of accepting help or being labeled a certain way. Kind of like what was mentioned before, not all cancer diagnoses should be career-ending. It was for me in my case. Concerns about this very situation are what caused my hesitation in seeking assistance. Now, in my opinion, moving into some of the areas of improvement, the most significant areas for improvement are provider access, fertility services, and overall the disability evaluation system process. So while my specialty care experience was great, my oncology team, both DoD and civilians, were always top-notch and in my corner. There was a significant disconnect between the primary care and specialty care providers. I changed primary care providers multiple times, and one thing that remained constant was the limited time and lack of availability of appointments. Appointments were either available or not, and when I did have the chance to speak to my provider, these interactions were limited really to 15 minutes of face time because they're limited to a 20-minute time window. As treatment progressed over that 18-month period, my list of side effects and residuals grew bigger and bigger. Now imagine yourself as a cancer patient trying to address, document, and seek care from your primary care provider in a 15-minute appointment window. This created significant issues and delays in care during the treatment process and following the transition and seeking care from the VA. When time was up, we were generally advised as service members to book the next available slot. Usually that was multiple weeks away. We need more than a 20-minute time window, and this issue alone is causing significant delays. An additional concern on my laundry list of residuals was fertility preservation. Now, there are countless resources available, amazing social workers that work here at Walter Reed. However, seeking and obtaining coverage for this unexpected expense was rather tricky. My wife and I were fortunate to have Maribel as our patient navigator to assist us and connect us with the Allman Foundation to help offset some of this cost. However, in many cases, fertility preservation could cost hundreds of thousands of dollars. While reimbursements may be available, the lack of process to support this causes unnecessary strain on service members. We also learned there's a 36-month limitation for the use of covered reproductive services for active duty service members. Imagine a younger service member impacted by cancer losing their ability to conceive naturally. As is, this coverage is limited to 36 months following that current reservation window. For these reasons, my wife and I attempted to use IVF services. However, we faced a process riddled with red tape and left without definitive answers on to how to use covered service. Overall, the whole fertility policy requires a closer look and clear guidelines for the life cycle of all reproductive services. The next item is associated with the base-sponsored transition assistance program, including SkillBridge, which were quite helpful during my transition. However, the timeline limitations currently outlined in the Marine Corps guidance restrict transitioning, specifically recovery service members being processed through the disability evaluation system to 90 days off rest. And that's actually a rate limitation where only specific individuals are allowed a certain time, although the DoD policies stipulates that they have up to 6 months. The overall issue really all boils down to the disability evaluation system process, where service members are evaluated for continued service. This process is inefficient, inconsistent, and requires additional structure to support the community care, continuity of care, and transparency for recovering service members. As I mentioned before, my case was referred just about 5 months into my 18-month treatment. From referral to separation, my case took 16 months to evaluate. Once I received my board decision, I believe I had 45 days before my separation date. So overall, the recommendations is really integrate the quality control process to verify that service members with a high likelihood of recovery are not referred to these boards unnecessarily. A simple conversation with specialty care providers could further inform these referrals. Allow service members to receive treatment first, then evaluate whether they're about to fit for continued service. The next one is enhanced communication and transparency for the entire process. My assigned liaison mentioned numerous times that the physical evaluation board was a quote-unquote black box. Once a package is sent, all you do is sit and wait. Imagine preparing for a transition from active duty without knowing your last day in uniform. The next one is expanding legal support to service members at the very beginning of this process. Currently, legal assistance is not available to service members until many months after their initial referral. While legal counsel was available, they also do not have insight into this black box. At one point, I was also advised to request approval from the PEB to receive an additional surgery that was medically necessary to treat my cancer. And then the last recommendation really is to enhance the mental health and transition assistance services so that impacted service members are more aware of their options. We're the Cancer Center has this figured out. We need to see this in the rest of the DoD across the country and the world. Overall, my cancer experience as an active duty Marine officer has provided insights into several gaps in the military health system. The challenges my family and I overcame seemed silly at times and added unnecessary friction to an already difficult situation. I'm grateful to my entire oncology team and the chance to share my experience and advocate for service members and families infected by cancer so they don't have to go through what I went through. Thank you.
Hello, my name is Shantae Drakeford again. I'm currently 40 years old, and as I tell my story, this is from a perspective as a spouse, and I'm also a nurse practitioner, so also as a medical provider. So I have more insight and expectations as I tell you my story. I'm originally from Washington, D.C., so I have a lot of family support here, which I understand is a major benefit. because while I live here and receive care at the Walter Reed Ruther Cancer Center, I know many of you are not as fortunate. For the past 9 years, I've been living with stage 4 metastatic breast cancer. This means the cancer has spread beyond my breast to my lungs, to my hip, to my rib, multiple spots in my spine, and my lymph nodes. I'm also triple positive, meaning the cancer feeds off estrogen, progesterone, and HER2 receptors. But this was my initial diagnosis at the age of 31. Unfortunately, for 6 years before my diagnosis, I was denied and delayed the proper diagnostic treatments and high-risk screening. My husband, who's now a lieutenant colonel in the Army, and I have moved around a lot due to his service. At each location, I saw different providers who dismissed my concerns. It all started at the age of 25 with nipple discharge and a palpable cyst. Despite these symptoms, I was repeatedly told I was too young for a mammogram and only offered ultrasounds. They assured me that it was just a cyst and there's nothing to be worried about. So for 2 years, I secreted nipple discharge and was told it was fine, unless it turned bloody, which it did, and that was my first intervention. Even then, they only removed the breast duct, not offering a mammogram or high-risk screening. I did request the cyst to be drained for pain relief, but upon waking from my surgery, I learned they only removed the breast duct and left the cyst intact with no explanation. 4 years later, the cyst became rock hard and 8 centimeters large. Finally, they intervened. A mammogram, a biopsy, and ultrasound confirmed that it was in fact cancer, where it could have been diagnosed as early stage. It already had spread to my lymph nodes and eventually already throughout my body. As a result, I will be on lifelong treatment, meaning this is a terminal condition for me, and there's no possibility for remission. While I can't pinpoint why I was ignored, I can't help but wonder if it was racial or age bias played a role. Regardless of the reason, it shouldn't have happened. Today, I receive excellent care at Walter Reed Cancer Ruther Center. But I don't hold resentment. Instead, I use my experience to raise awareness and prevent similar situations. Here's some pros and cons that I want to point out. For the Ruther Cancer Center, they have exceptional providers. They follow evidence-based practices and contribute with respect and care for us like family. They have an abundant amount of resources which I have utilized myself personally. The center offers various things such as pelvic floor therapy for sexual health, palliative care therapy for pain management or overall well-being, oncology nutrition services for weight management and healthy eating, therapy services to cope with the stress of cancer and life adjustments, complementary therapies such as mindfulness and meditation, dynamic social workers who are always there to help, the Young Cancer Program, which provides activities and support specifically for young adults with cancer, amazing nurses who offer personalized care, making treatment days much more manageable. And then I think, which is mostly important, that I have the capacity to bring my civilian support system to my appointments, which is crucial to my well-being. So some cons, there are some gaps in care. I recently experienced a 1-year gap in my palliative care due to a provider vacancy. Now, as of today, I've heard that they have returned, but palliative care is essential, especially for those living with long-term cancer diagnosis, and I did sort of suffer without having it. When I was first diagnosed, I had a dedicated nurse navigator who helped with the appointments, resources, and overall support. But once I became, stable because I'm metastatic, this support stopped, increasing my stress. And scheduling appointments, which I know all of us can attest to, can be a daunting task, requiring repetitive paperwork and long wait times. Previously, there was a lab technician on the unit who drew pre-chemo labs and a pharmacy that will provide non-chemo related medications. But now I'm forced to go to the main lab and the pharmacy, which causes some inconveniences because it can extend my treatment days. I understand I'm fortunate to receive excellent care at Ruther Cancer Center, because many of my civilian friends with metastatic breast cancer lack these resources, quality providers, and programs that are available to me. I'm grateful for Mertha's commitment to excellence. However, it begs the question, would I receive this same level of care at other military treatment facilities? The recent addition of the DoD Cancer Clearinghouse search tool is a positive step. This tool can help me navigate the diagnostic process years ago. So it is encouraging to see some progress. But despite my challenges, I do have a positive outlook on life, and I do enjoy it fully, as everyone who encounters me understands that. I have a farm, I still work at least once a week, I travel, I continue to make my life's plan. And the programs and resources at Mertha Cancer Center play a significant role in my well-being. I mean, I'm still in my first line of treatment, and typically with metastatic cancer, you keep going to therapists until you die. And I'm very fortunate to still be on my first line 9 years later, just to attest what type of quality of medical care I do receive, whereas standardly you die either 1 year or at 5 years. So my hope is that no one else experiences delays in proper diagnosis. It's far too common of a story I keep hearing. And we need to be seen if something and taken seriously and have all the measures accounted for to the T for me to see that there is something abnormal. Thank you.
Good afternoon, ma'am. As I stated before, I'm Staff Sergeant Brian Ernst. I'm a Massachusetts Army National Guard soldier with 10 plus years of experience. I've deployed twice, once to Afghanistan in 2014, and again most recently to Kuwait in 2023. While on my last deployment, I had to leave early to Walter Reed via Germany with a diagnosis of Hodgkin lymphoma. Many obstacles present themselves when thrusted into the battle of cancer. There are two I wish to address today. First being non-medical attendance for single soldiers. With having no spouse to lean on, a non-medical attendant greatly aided me in the biggest fight of my life. The sense of security and comfort this provided is something every single soldier should be entitled to. I had to fight for mine while simultaneously fighting cancer, and do not wish for others to have to suffer the same strife. Second, and this seems to be a common theme today, the second obstacle that I incurred was a delay in care. After landing at Walter Reed from Germany, I did not receive a PET scan or biopsy for nearly a month. Time is of the essence when treating cancer. If it's not seen early enough, it only gives it time to grow and spread. It was not all bad, as while being treated here, I was able to utilize fertility services, participate in the cancer survivor group, and several of the lovely members on this panel, and also mental health services, just to name a few. I would like to thank the doctors, nurses, and staff for their professionalism, their thoroughness, and above all else, for their kindness. Thank you for your time today, to hear all of our voices, and for your willingness to use these voices to affect positive change on the organization and its approach to treating cancer.
Thanks. That was a very powerful story, so thank you for bringing it to our attention. I want to hear more than speak. So some of the common themes I'm hearing, though, are delay in diagnosis. And I think it's particularly, I think, in the research community, we've been hearing and seeing more and more poster sessions coming up in our own research of how many more younger people are being diagnosed with all sorts of cancers. So I think there is a growing awareness, I'm hoping, across the military health system, especially with our population, that we need to be doing earlier screenings. And screening standards are dropping in terms of ages. I don't know where they are on some of the ones that you've mentioned, but that's certainly something we need to look at. One of the things I'm also participating in, that the White House has started on its health research initiative, and this is about how much money are we directing as women grow as a population in the military. And we're doing a lot sort of on the cancer side. In this FY24, we're spending $500 million, some of them is healthcare related, but it may not always be in exact places that would help you all. But I definitely think earlier screening is one of the things that we've got to be taking back as a policy. I was talking to Dr. Schreiber ahead of time here about sort of the privacy aspects. That's always a concern. And I just need to let you know that this is an age of data. This is an age of people want information. It's an age of sharing of information. And I want to let you know that we are always at the front lines of trying to protect healthcare information. I know that HIPAA applies a little differently for active duty. You know, you sign up, but it's not always as easy as for those of us that are civilians to have that. But the fact is, we are trying very hard in health affairs to understand that personal healthcare privacy needs to remain. We understand that the commanders sometimes need to know, but they don't need to know why all the time. They just need to know whether you're deployable and when you'll be back. And so we are trying to find a ground in there as we feel the need, as people think about going to war. What do people need to know about their people, and how much do they need to know? That's certainly that. I feel for the lack of providers. I'm certain you've probably heard that everywhere, right? We have in the civilian healthcare system, we don't have enough specialists. We just don't. The specialists we have are terrific. We don't have enough of them in our military health system. It's a problem across the United States, a problem across the world. We've been hearing it. Yesterday I was participating in the future of healthcare, digital healthcare, how we deliver care differently, because we just not going to have enough people. Our population's shrinking, not enough people going into medicine. We haven't enough of anything, much less just specialists. So that's something we're trying to solve as a larger system, which is going to take a long time. Anyway, when you mentioned sort of the personnel policy, just so you know, I report to the Undersecretary for Personnel and Readiness. We work very closely with the personnel folks. And we've been working really hard on with some other policies. And so I'd like to hear more specifically what you're trying to do. I know the services have some policies that don't always are different. And so that can be a challenge that we have to intervene at times. But those are some of the big things I heard. I want to hear more about what you would like to go ahead and talk.
So I think we've kind of mentioned it in so like the fertility treatment, right? So I know things have changed, however, it has not changed for surrogacy. So I had to make a decision, right? $140,000 decision, right, to have a kid or not. And I know that funds are limited. I understand all of that, but things have changed since 2020 when I had 2021 when I made a choice. But it was come up with $14,000 to freeze your eggs, and then be prepared to come up with $110,000 to $120,000 because TRICARE is not going to cover it. I thought that I could have my buddy reset up. They would do it, and it's hard.
Right.
It's super hard. I deployed 5 times. I've done everything. Well, and I can't have kids because I don't have $140,000.
I hope you've noticed there have been some changes. There have, extending sort of, fertility preservation has been something that we've been trying to tackle for the last several years. Especially we want, for those who are experiencing, both cancer or just for other reasons, right? If you can't have a child, we want everybody to have the family that they want. So things have been changing in the building. I'd also say that if anybody follows what's happening on the Hill, I was just reading today, the House and Senate each have their bills now, and there's several very promising things there. We don't know where it's going to end up because it's not law yet, and they'll have to hammer out, but there's a lot in terms of both for preservation, for paying for that. And then there's, who can, what else can you qualify for in terms of IDF? I mean, just flat IVF, not even for people who are ill, just IVF, and a certain limit on it, at least they're doing. So we don't know where that's going to end up and where the department's going to end up on that, but keep your eye on that. I think that's coming. Things seem to move slower than I would want, but they're moving in that direction.
I just hope also the budget people are in there, right? Because there's a lot in that bill,
I know,
that becomes unfunded requirements.
right.
And so someone has to pay for it. I joke and I say it's all spreadsheet money. I know it comes from somewhere. So a lot of it, and I did I have worked on the secretary side of the RV, military personnel policy, other health affairs as well too. So I understand the problem, and it's hard, especially if it says that you can do something.
Right, that
versus,
may not shall.
Correct. And a lot of that's given in the leeway of when it's all in bill.
Yeah.
Where does it play out? And sometimes I feel that more attention is given to a weapon, a tank, and a plane than the healthcare side.
I did want to kind of like piggyback and kind of almost support Erica because I understand the strike on not having the option of surrogacy or even adoption. For me, it's specific because the cancer was off of my mom's.
Right.
Preservation wasn't going to be an option. Otherwise, it would kill me literally. So to have that component where I could possibly adopt or like I did participate in reproductive care with IDS because I had infertility problems prior to my diagnosis. I had the successfulness of having like eggs and embryos frozen. I could have that option of surrogacy as well. But I think that is just as important, just to kind of piggyback on what Eminem was saying there.
If I may add also, ma'am, I think that the policy changes that we're seeing to fertility space are very promising. In my experience, and this was before the most recent changes, and honestly, whether the most recent changes were put into effect doesn't even necessarily matter if the Humana or TRICARE representatives that are answering your phone when you're called to inquire about your coverage are not informed on what the policies are. So, for example, in my situation, when I was working with Mary Fellis, this was almost 2 years ago now, when I called Humana to get informed about my coverage, I was told that fertility services in general, oncology related or not, were only covered for married active duty members. When I was told this by the community representative, I did ask to speak to their supervisor on the phone, and the supervisor repeated that same incorrect policy to me. And that, triggered me going crying literally to Mary Bellis and my case manager at the time, like trying to find the truth of the policy. And it actually escalated to us visiting with the Humana representative that sits at Walter Reed. We had a meeting with him one-on-one. We reviewed the policy together in person, and I was ultimately able to freeze my eggs. However, I do not believe that if I didn't have the privilege of being at Walter Reed for my treatment or wearing an officer rank and having the privilege of having the courage to go up and stand up for myself, I do not think I would have been able to freeze those eggs.
I wasn't I'm a little jealous, to be honest, that I was found out at JBLing because we didn't have all of this. I was on my own at 40 years old looking for someone else that had endometrial cancer. And there wasn't, because everybody was like 60, right? It was COVID, so valid that a lot of things were different then. You didn't have a lot of needs, but it was extremely hard. You feel like you're at an island on your own. And when I hear the amazing experiences that you guys had, it's kind of like I wish, I don't want to go back, so I don't want to go through it all again. But if I could have had that support, I think it would change. I will highlight, I think I'm also an anomaly because my original oncologist actually IPCS'd here, DC, and then he did. So I have kept my original oncologist for 4 years now, and that continuity of care has probably been the most important thing. He knows me, he knows Erica. He knows that I have my crazy brain and that he needs to schedule the meeting in the afternoon because I'm going to have 700 questions.
The person versus the disease.
Right. And I cannot, thank him enough for, I think, dealing with me. Because he did it with care and compassion and continues to do that to this day with either other things that have come up and helping me navigate things that it takes 90 minutes right now in the National Capital Region to get a doctor's appointment. I'd average than your call, right? And so it's hard to say that I have 90 minutes to sit on the phone. But I have to, because I have to take care of myself and I have to take care of my mother if you're going to. But to your point, what happens for that young staff sergeant? What happens to that young corporal who doesn't have the ability to sit in their office with it on hold on your team's calls? Right, and that's why I just started to be our relation or represent.
I think if they want to help all TRICARE beneficiaries, like if you want to make a change within 30 days, expand the call center that takes the appointment line and the calls, because that alone, reducing that wait time, will make appointments much more accessible.
Yeah, I don't know if you've heard what we've been trying to do. We understand that because of the provider shortages, and when I say providers, I also mean all the support around the providers, the med techs and the labs and everywhere. We're short everywhere. So, and so one of the things we're really trying to do is what they're calling like the digital front door. We've got to get it where we're a little bit more like the private sector, where you can start scheduling and doing things through your phone. and not just calling, but having an app that you're going to be able to get through to something. So, or a telehealth appointment. We're doing 5 sites now to really get an excellent platform out there. And then as that gets up, then we do it and do it more. That's a little bit more common, as you know, in the civilian healthcare system, but we did it sort of, I'd say, hodgepodge through COVID, and it really needs to be, a common platform that all of our NTFs, since we're starting in some of the 5 big ones, and then it's going to start rolling them out, so that you don't have to maybe come in if it's just something you need for like a refill or something. You don't need to show up there and stand on the pharmacy line for that to then make the call. So we're hoping that that's going to do that, but like everything, it's going to take time. We're a big system, but we are trying to get more in current with how our beneficiaries can access our system.
Along with that, I think the pharmacy system that they have at the Pentagon, right? So
Yes.
I'm assigned to the Pentagon. It's not big enough for all of us, so I did it off building.
Yeah.
So what's great is that I can put my refill in, and then 24 hours a day, I can go to the little machine and scan my ID card.
Expanding that, we're trying to expand that
And
everywhere.
so,
Yeah.
I think that a lot of us have a lot of scar tissue and frustration
Yes.
with our stories. Unfortunately, I don't believe a lot of it's necessarily all with the health part of it.
Yeah, I heard it can be right, like you were talking the disability system, we hear a lot about that.
And so it's I think so these small wins,
But
small quick wins can give you a lot more of an agreement win coming in, right? And I had a boss, he's now over at OSG, Mr. Rangers, he always tells me,
Oh, yeah, loved it.
he always told me is what is the second, third word effects to that? Because we have a recruiting process, everything else. So my story, I try to not be negative. I actually, when my niece joined the Army, I did not put my
Yeah,
experience on her. But if you are sitting there trying to decide if you want to join the military and you're hearing the stories that we have about we can't get into healthcare.
Right.
My boss has to know about my diagnosis. The things that I can be a lawyer, I can run for Congress, I can be a doctor, I can go try and be a president of a CEO company. My boss does not need to know about my medical process. In the Army, they do.
And that is a common objection. When I served on recruiting duty, that's an exact objection that we have you deal with the high school students. Is that why does the commander need to know this information? So long as I can work over here, they have no need to know.
yeah.
That's an
Yeah.
interesting, set of skills to get past that objection. But
I gave up command knowing it was the right thing for myself and to take care of myself. Also being that I'm giving up my promotion. I have turned around as lieutenant colonel. I was successful. I'm happy with that. But it was a hard pill to swallow. Like you said, you were in treatment and had to go to physical disability board, right? And you're going through this and you're like, I've already lost so much because I have cancers. And now I'm missing this. And it puts a negative, it takes all the 20 years of great things and great people I've worked with, and it's really kind of made it negative. And I have to definitely check myself to not put my experience on someone else. And it's hard to do that.
yeah, and that's one thing. Eventually, is Scrum allows us to have kids. I don't want to put my negative experience. The only reason I accepted my work findings is because I had lost faith in the system. I had lost faith in the Marine Corps. I was tired of waiting. I was not going to appeal and extend this process out another 4 months for more unknown kind. I was just ready to move on.
I mean, as you know, we've always talked a lot about the recruitment and retention problem that we have. It's just fewer people with the propensity to serve, and this is something we're trying to do. And we understand that saying that our healthcare, once you're in it, is really good, but getting in it is a challenge. We understand those access challenges. You guys all live them. I'm sorry for that.
And he's also
Do you, Craig, do you or your team have any suggestions, any thoughts? Have you heard anything you'd like to comment on?
Ma'am, so I'll start with Maria and then Maria Ellis, who just showed us.
What do you think?
Well, I am an oncology nurse and have been an oncology nurse for over 35 years, mostly in the civilian world. And I was hired here in 2022. And it was an accommodation for me to get, to learn about this whole new world and to make the comparisons and also just to see the opportunities that we have. So I just I'm telling you this so that you see that there is support out there. And I was told by some people, give it time. Since when you're in a role and you see everything, you're just like, your mind is going, I want to do this and I want to do that and I want it to change. And yesterday I wanted to change. And I have been blessed with support. I have cheerleaders that are helping me to grow this role, to be there. Unfortunately, like survivorship here, when it was decided that every cancer center needs to have a survivorship program, it is really supposed to be delegated over to the primary care group. And those primary care providers they're having their own problems. So let's say, yes. And a lot of them have never really had any education in oncology or understand about the long-term side effects of, and they don't really know. And what we're learning now is that the oncologist has to take a more active role. And there have been studies that show that then coordination with the primary care is the way to go. And until then, what they're doing that Martha is those docs are picking up the phone and they're talking to each other. And they hired someone like me and they're saying, when you're done with active treatment, meet with my patient. And I'll be saying something to the patient that they've heard before. They know that they heard it before, but they weren't ready to receive it. So that, again, that's what I just want to communicate, that we are learning, we are listening, and I'm hoping that in my role that we can continue to grow, and I can partner with people like Mary Dallas and the folks here at Shams that pay for my son.
As we've all heard today, cancer does not discriminate with young adults, active duty, or children of active duty members. As the young adult patient navigator, I work diligently with the oncology social worker team over at the Martha Cancer Center. In that role, I support each and every one of the young adults who are referred to the program. First off, for fertility restoration. One of the challenges that we noticed is that sometimes people are referred early. Sometimes it's just the crisis and the referral comes. When someone's being medevac, we need to know that when they hit the ground. We want to have that fertility conversation. My role is to talk about education, logistics, tackle the insurance benefit, get that referral in, get it approved, get the patient an appointment. If they don't have the finances, find the money or find some of the money. It's kind of hard to do it if you have one thing notice and the patient needs surgery or cancer treatment. Most of the time, now that we've implemented the program in conjunction with the cancer treatments, with the other oncology social workers that work diligently to handle this, most of the times the consult comes to me, right? And one day notice is not enough, so we need more notice, right? So that's something easily fixed. Right? The policy that impacts the surrogacy, the being married, the surrogacy is not in the works at this point, or maybe it is and I'm not aware of it. I am working closely with the DHS. We are aware that they've extended the 30-month period, but it's as long as you're active duty. So if you're a veteran, it doesn't apply, right? Or a reservist, it doesn't apply. That's right. So something, we're truly looking to support our military members to building their families. Maybe we can look at that slide. In terms of the active duty parents who have children who have cancer. Now they're not at the table today, right? The pediatric, but they also deserve a voice, right? What is their experience? How is their career being impacted? As we all heard today, everyone here has had to put their military career on hold. That is a big disappointment. That breaks everyone's heart. You committed to it for the long haul. We didn't expect this. So we can do something about that. We can also do something
primarily educating the PCMs in terms of trusting the voices of the young adults. The cancer does happen to young adults. Education across the board, I believe, is key to building that trust, right? So the voice doesn't come just from you, it comes from the head, saying, yeah, this does happen, we have the data, listen to your people. I'm gentle on clinics, I'm sorry to cut you off, but also the radiologists as well, because I've been directly denied from an actual radiologist as well. Right. He told me, like, you don't need the mammogram sign. I was in the room. So it's PCMs and the providers, right, and radiologists. And another concern regarding the scans and the biopsies, why do we need to wait? We proclaim early detection is key. So let's put it together to early detection. If we cannot handle it because of manpower right now, can we subcontract to get that done? Is that something that we would consider as an agency to support the early detection and immediate treatment and avoid delay of care?
And I think it's like the referral process, right? So I was shocked that after 40, which I'm supposed to get a mammogram every year, I still have to get the referral from my PCM put in to get the mammogram. Even though I have a letter from Walter Reed telling me to go get a mammogram. And so as a patient, right, I'm in this circle of, I got a letter from Walter Reed telling me it's time for my mammogram, call the appointment line to get a mammogram. I called them, I'll hold for a long time, and they said, we don't have a referral in the system, so contact your PCM. Now I will tell you, Genesis messaging is amazing. I'm a huge fan of it. And I was able to message my provider, they put the referral in, that's time for me to call that appointment line to get it. Even though it's an annual thing I have to do, like, and obviously it wouldn't have, helped you guys because you're not of the age. But if I didn't have to go through all that, I would tell you that unless I'm right on my metros and I'm getting yelled at, sometimes I'm just like, I don't want to deal with it. Because I have to go through all these hoops to even get into the screening appointment that's needed.
But just as quality of life.
Right, and it is, there's a lot on the service member of, when you have a nurse case manager, who helps you with it, and what qualifies for it, because you're running around trying to get all these doctor's appointments, and who you go to, and what do you do. Ma'am, you brought up something that I want to bring up that I think is also another great thing, and I was not ready for it at the time, and luckily my primary care doctor and oncologist both convinced me, so fit to win clinic that the kind of has. I just went to it yesterday, actually, and that nurse there looked at my entire medical record. And when I sat down, the first thing she said to me is, she's like, you've been through it for the last 4 years. How can I help? And I cried. I'm going to be honest. I cried because she got it, right? It's,
How can I say yes instead of how can I say
right. And so I'm not going to make you change your whole world, right? So let's talk about small things, and here's the other things you're going to do. Like, yes, you can't go run like you used to, can't go lift like you used to. Let's start you out small, and let me get you with an exercise kinesiologist that can tell you about functional movement versus lifting heavy things very fast. And I went to physical medicine, and they're doing acupuncture on me now. Yeah. Right? And once again, it's that combining of the West and the East, and it's getting better, right? There's a lot of great things, but I think we have to do more of that and do it earlier.
Yes.
So we're not in these
I
situations.
just wanted to touch on the coordination aspect that you were talking about. From the time that I got an X-ray and a CAT scan in AJ in Kuwait, I spent 9 days and got 2 CAT scans while I was in Bonstuhl in Germany. Why wasn't there that coordinating effort when I landed? Like, I shouldn't be waiting a month long, but they know that it's a problem. They're passing me off back here because the experts are back here. That there shouldn't be that delay. We're costing more time and the propensity for it to spread throughout my entire body, especially with lymph nodes. It's a highway, so it spreads pretty quickly. And we caught it pretty early on from all the early scans. So I didn't mean that.
No, it's a really good point, because it's not just with the fertility preservation, which, a lot of times we have a window, right? Most times we have a window, but it's a short window, but it's not a one-day window, right? Like most people that I've worked with, at my tenure over at the Martha Cancer Center in the last 3 years, most people have time. We do have some patients that have 2 days. 2 days to do this, right? And then there's no in-network provider for the males, right? And if there is one, you have to travel. So you can't leave the hospital to go do this, right? Then we make an appointment, then we need authorization, so there's delay. So we don't want the delay, we work with the patients, get them to pay, and then work with the reimbursement process, which could be a nightmare, right? Right, so we're tackling those barriers, we're addressing those barriers, we're filling the bridges to make it easier, right? And that there's been an improvement in the past few years because there's collaboration, there's communication, and there's partnership between the Martha Cancer Center and the young adult programs and the outside agencies. My concern is for those other institutions that don't have a patient navigation program, that don't have a young adult cancer program, which is the majority of the population that we're serving, right? So who advocates for them? Who takes the baton and say, do not worry, I will make the phone call, I will bark whatever tree we need to bark, we will get the money, we will make your appointment, we will call TRICARE, get that off, we will call and see what's going on with that claim that's not approved yet, or let's appeal. How do we appeal? This is what we need to say. Let's manage it. And this doesn't happen in every other institution.
It's so essential.
Yeah.
I made every single one of my phone calls to the fertility doctor myself. And right, I didn't know what I was doing. I didn't know I was speaking clearly and be honest.
And no one explained to you that this is the benefit that you could access, and we need to access it immediately. We need to make it urgent. We need to do our best to give you a chance.
So I was told to come up with $14,000. That's
What year was this?
this was in 2020 at JBS.
Yeah, so the rule is just changing.
It is yet
Right, recently changing.
yeah, and
Here, why?
it's
I need to cheer for some.
but
Single soldiers get left out of a lot of things, man. It happens constantly, and we get the runaround a lot more than, say, someone that has a spouse.
So, right, but the misinterpretation of the policy is that you have to be married to preserve. But that is not true. That is not true. You could preserve as a single person. The clause used to be that if you were legally married, then you get access to the IVF. Your spouse, who's not a military member, could get the IVF. But we need to write a referral to include all these verbiage and put it in correctly. And so there's a lot of education on the provider side to make sure the verbiage is correct. And now we have a new form, the DHA 407, which we're now tackling how to implement that to expedite the process, to have us streamline it, to make it easier. So we're working on that. It is a challenge, but we will succeed, just like we succeed in other areas. And it is a challenge in other institutions where the education for the fertility preservation is not there for the providers to understand the policy, right? Understanding the policy from the provider perspective, at least to say, wait a minute, you have a benefit. Let's put you in contact.
Right.
And the provider doesn't have to dissect the information, comprehend the policy, or implement it. They just need to be aware there's a benefit. So let's tap into it.
so another policy that's confusing is the assignment policy. So if you are married and you have your spouse going through this extremely compassionate reassignment process that you can go through. As a single soldier, there was no process to move me from JBLM to I asked for my mental health. I was not going well, secluded on the West Coast during COVID by myself. So I went to my command and said, hey, I need to move to the East Coast. I need my support system. It took the HRC, the tab to call me, which I totally respect by my direct supervisors. They didn't tell her what was going on. She called me and gave me that opportunity. It all of a sudden, an assignment was found in the pen. And there's no other way to move me. So I'm doing everything I'm supposed to do. I'm raising my hand and saying that I'm struggling. I could not get into a mental health appointment. I went from diagnosis to my first mental health appointment was 6 months.
And that is a huge difference between what you experienced at Walter Reed.
Right, 6 months. And basically I basically threatened to say I couldn't get mental health care on Twitter. I'm being honest, right? Because I was struggling and I knew I was struggling. And by the way, I also had a phenomenal mental health provider. I got her. She tried to keep me when I moved here because we'd gone through trauma and some other things. But I had moved, and so I had to start all over again. Because there's no, even in a telehealth world,
Yes.
because now that appointment needed to go to the West Coast and I'm on the East Coast,
3-hour time difference.
she was willing to do all that. The policy said I couldn't because I went from West Coast to East Coast.
Yeah, it's because you're cross. She's
Psychiatrist,
Psychiatrist was.
and it's like I had this connection with this doctor that was making
Yeah.
huge, and I had to basically do I stay there for my mental health doctor,
Right.
or move
To get the care you needed.
into like the support more than anything. And so there's that is some things that he could do, especially in a telehealth world. Is I'm willing to either stay up later, how could we do that? So you could have this
Yeah.
continuity of cares throughout the life cycle. And for me, I was very, very blessed, right? So I only had to do topical chemo. I've not had to do anything else. And I think sometimes I'm treated as not a real cancer patient. So I didn't have treatment.
We all have imposter syndrome sometimes.
Right, and again, I've had a real hard time with that, and it's because I've been so low risk. I will tell you, I've done it all myself. I didn't have any of this
Yeah.
support.
The young adult program focuses on behavioral health, which is provided by Elena Nazario and Stacy Springer. They provide behavioral health, which is specifically related to the cancer diagnosis. Within that scope of service, they also provide support and intervention interceding with the command in terms of like the demands of the job to kind of de-escalate the demands on your physical body while you're undergoing chemotherapy, radiation, surgery, chemo brain, exhaustion, mental health breakdown because you need a mental health day. And we also provide, we co-host together a young adult club. We call it the club, the young adult club or the chemo club. And we meet once a month, and that's where the support begins. And I am really sorry that you didn't have that, because you wouldn't have gone 6 months without the benefit of having an oncology, behavioral health social worker to help you cope with your diagnosis, and a support group, which we provide at the Walter.
Elena literally came into my second infusion.
She did.
Stuff was going sideways with the Army and then a little bit medical-wise. And I just said to her, she's like, do you want to talk to someone? I was like, I feel like I'm not being listened to. So the mental health aspect is a huge aspect of it. It's huge support because it just puts you in the right frame of mind.
Right.
The other thing I wanted to talk about a little bit, like the threshold of a non-medical attendant, especially for a single soldier such as myself and others on the panel. The threshold they were telling us initially, until I had to fight and get my mother and my father to be able to come down and take care of me when I'm going through chemo, was that I basically needed to be on my deathbed. It was like, those 4 or 5 days after you have chemotherapy are some of the worst days that you can have. You need someone to make sure that you're hydrated, that they're feeding you food, that they're just checking on you. Are they still breathing? I can't ask someone else to do that from the SRU and expect that I'll get the same level of care that I would from my parents. I'm fortunate enough that my parents are able to down here, but there are a lot of single soldiers that don't, and that's what they tell them. They're like, well, this is what you get. You can get a caregiver, but they come at their own cost. Versus a non-medical attendant, it's not much, but they're compensated someday.
And this isn't a provider issue; it's a systemic policy issue. And so just like he said, I have a very similar situation where I had to get surgery outside of TRICARE. To get funding for my wife to accompany me, I literally had to be incapacitated. My oncologist was willing to sign it, but like the policy is and what's in black and white, I can't do it because it's in black and white. I saw the letter the moment I woke up from surgery. A few hours later, well, that wasn't Luca anymore. I saw the letter. Here's your ADMA letter. Your wife is now, has funded travel authorization to accompany you to the surgery where I was bedridden for a week.
And that presents a big challenge for the military community, because you take pride in having a clean record. You take pride in not having those marks that state you're not capable. You are a soldier, and you want to be seen as a soldier. And you're fighting a different battle, and that you shouldn't be deemed on your deathbed to be able to get some help, or the documentation needs to be blurred in order for you to get services and the support that you need.
To put it bluntly, a lot of us, they ask for a pound of flesh. The least that some of these policies can do to enable to support us after we've given everything that we've been able to throughout our careers, the give back should be at least, if not equal, 3/4 of the way. Meet us somewhere.
And when we're speaking about caregivers, they uproot their lives to come take care of you. And you mentioned respite care. Where is the respite care to have another enemy step in? I haven't seen it. As the patient navigator, tackling the barriers that you guys encounter, looking for resources, I haven't seen it yet. And maybe it's just, I just haven't found it because I just haven't found it.
And that goes on both sides because my caregiver is the service member. Rather, like he still has to do his duty if he's well and healthy. And so he has to get all these things to kind of get signed and permission and command of this and that just to care with his wife. So it goes on both ends, scramble up.
And I think that we can take some lessons learned from some policies that change, right? So, for, under the fertility, under the access to reproductive care, there was some huge movements that happened in that policy on what it can happen that, okay, if the female is going to have their eggs retrieved and you're a male service member, you need to support them. You could also be on leave and absence at that time. There's been some big changes. I just think that it's been changes that are done, and I gave a policy, it's hard, but it's a policy for, okay, so only for IVF. So how can we apply that
In a vacuum.
to all these other cares? I think it's a huge win.
Yes.
That was a huge win across the board. I think it's frustrating to sometimes hear the negativity with the access to reproductive care because it's really about the full reproductive care, not just about a termination.
Right.
And a lot more people have gotten a lot more access because of that. And I really hope that from a policy standpoint, we're looking at the lessons learned on that to transfer it to other policies so it's not such a stovepipe. It has changed.
I consider that one of the best things I've done during my term with this administration is spearheading that effort. And I will say that the reproductive, the people being allowed to accompany someone during IVF, even though at this time you pay for your own IVF, depending, if you're in active duty, we're, a lot of policy around that, as was allowed, and that not just for the person receiving it, but that your partner, your spouse, your child can come with you and be paid for it is a huge win because everyone needs the support support system. And I'm very proud to be a part of that, but I wrote that down, what is that going to look like, for what you all have gone through.
If I may add, if you will consider at some point the surrogacy aspect of it, would you include some legal support? Because surrogacy requires legal intervention and you need expedited legal advice. You need contract with the person who's carrying the child. You need health insurance. There's legalities that accompany the surrogacy. And I understood from listening to you that getting legal advice took a long time. And so maybe there should be some clause in there to expedite legal intervention if that is available.
Yeah. The surrogacy piece is a very hard one for the department because it's creating an entire system and especially a beneficiary whoever, if the person who is carrying the child is not a beneficiary, there's no way for us to extend that person to be a beneficiary.
Yes.
You must be active duty, family, an active duty family member,
spouse.
nobody will spouse, right?
I think that there need to start with it though, ma'am, right? I understand that. I completely understand that, right? It's especially when you don't have a contract with the military and now you're trying to get health care, it's all that other stuff.
Right.
But I think that we've done great things with IVF. We have. But I think it's try to figure out what's a pilot on the surrogacy side, right? So if it is another active duty service member that would be willing, right, to have, and honestly, what type of pilot could be done to try to figure it out? Because right now, I will be honest, we have to figure out the world ourselves, right? And so legal assistance can't help me with that contract.
Right.
Outside of that, right? So now I have to have a lawyer fee, and I have to have, all of this other stuff. So what type of pilot could be done? Or maybe it is that, okay, if you're going through this, legal can help you, right? So what other things could we do? Besides just, paying for the whole surrogacy process, I think there's pieces that you could get a lot of bang for your buck, even if there's there's a small pilot to help figure some of this out.
I think this is identifying, wonder the pilot identifying like what the actual pain points are. We're not going to figure it out all at once.
Yeah.
Okay, now personnel policy has been developed after many, many iterations.
Yes, yes.
I could bring.
Yeah, I was going to say, you haven't had a chance.
For one, I just retired from the Caregiver after 30 years, and the last 22 working in gynecologic oncology and at both luxury sites housed in CI. And I do know something else about an advanced practice nurse. I don't feel that we have enough advanced practice nurses that are specific to oncology and are valiant as well. And we need to find a way to do that because there's so much more that we as advanced. I mean, I've always worked in a extremely collegial team. You know, when we walk in and we see that patient as a group, and I know he's going to do or she's going to do what they have to do in the OR, and I'm supposed to pick up all the pieces and make sure all these pieces are together, and this patient is well educated and well cared for and navigated. And that's what I did, and that's what makes the difference from how your experience runs. And nurses there's lots of great nurses with lots of experience. The nurses in the chemo room, the case managers who work tirelessly. But they need support. Because what happens is, after several years,
Burnt out.
they are and got to retire, and their positions eliminated. And now, you know, there's even just being able to do telehealth as a nurse would have been fabulous.
We are going to get there. We are absolutely going to get
Nursing,
there.
because nursing, as they can, I'm a clinical nurse specialist. I'm not a nurse practitioner. I can't charge all my work.
It's the coding in the building, and
Right. Legally, also, I do a lot of end of life work, and how many times I've had patients who came in and it really is their very last days, and I can't get someone to help me with their will or any of their ideal pieces at their deathbed. And what are we going to do? What's the family going to do? But as that's a big issue. So I would love to see better coordination. I think what's amazing about our work at Northa is how we do work as a collegial team, that we value the other's strengths, because we cannot each do this. And there are study after study that shows that a comprehensive cancer program and support is the only way patients do extremely well.
you need a little team.
That's just recent, like the multi-oncology, relatively recent. Because when I got diagnosed, I was going from clinic to clinic to set up the initial appointment, got to tell the whole story over and over again to every new provider. But this new process that thankfully is not a thing, I unfortunately get to experience it.
And I want to highlight what she's talking about, because Sarah actually took care of me when I switched over from JBLM to Walter Reed. And I was unfortunately a Genesis patient in between. So when I PCS here, and I called the PCM to try to get everything set up, I was told I didn't have cancer because they couldn't see it in my medical record. And that was great. And Sarah really took that, right? So over the phone, she was then able to make the connections, figure everything out while I was still on PCS leave, get me in to get meds started and everything else. And so you do have these individuals, especially if it's cancer center, that are going above and beyond. And if someone would wait to this after my treatment, my initial treatment, it was a game changer, an absolute game changer. Because all of a sudden, anytime I go to OBGYN oncology, they're like, oh, let's make referral for here, or referral for here, or referral for here. And like, I have to go to my primary care doctor for things.
Yeah, the social work, the team at Wertha is amazing.
I did want to highlight, I was diagnosed in 2015, and like I mentioned, I was initially metastatic. So it's all over my body. This is lifelong. This is terminal. And my first meeting, I was fortunate, and sorry that some of you guys didn't experience that. It was interdisciplinary. I had a radiologist meeting. I had the social worker meeting. I had the young the coordinator there who understand my youth needs, right? I had the social worker. Everybody there was there. And I think that kind of catapulted my mindset in that positive realm, because They gave me so much encouragement that I'm going to make it, and I'm going to here on it. And I honestly don't think I would be here even because I've been here for 9 years now with it, which is beyond the statistical realm if it wasn't for those type of graduates. And so the support that they need to get that continuity of care with the staff support is really vital to us patients, because I think, their family was there most of the time, and we're there all the time. And we know, like, I don't know, at least me, I know they're everybody.
Yeah, it's a village.
Exactly. Yeah, so it's very vital that survivorship, on top of like clinical trials and things of that nature, and advanced care practices and medications are at the forefront of the LID.
I would like to say they'd be fabulous if we could mirror everything that Pete's has done. They've done so many things, and Dr. Strapper, is in the breast clinic, having this one stop, but that a group can do that and be able to have that available. Even if I can't have them all in the room together, to have them be able to be in that communicating together, right? But yeah, it's one of the main towards it, and with the test-based patient being fairly cool along me too, and have done so much to, again, work on that coordination. And that's just been in the last couple of years for these things. So over and over and over again, it's just the thing. We need coordination. We need to have that value, and have, when someone is really diagnosed, to have that access to their team. Unfortunately, there are the barriers until they get diagnosed that we also have to make clear. We have to do that with community that. And a couple of things that would become okay to hear about that. And in my new role here, we started an Omnivence-wide rectal cancer active surveillance virtual tour board. This monthly meeting is designed to provide consultation and advice from a variety of experts in various disciplines from across the wider DHA direct care system from military treatment facilities and med-science. So the purpose of this consultant board is to review and discuss difficult or controversial cases, and is a place for the colorectal surgeons to obtain collaborative advice, which is especially effective for surgeons in remote locations that may not have access to expert opinions at their own facility. The meetings are presented via a secure website to maintain patient confidentiality. And so far, we've had 2 monthly meetings, and we're working towards the creation of a standardization the care of rare rectal adenocarcinoma in the watch and waste patient population. Our goal is to increase these specialized tour boards across the DoD for rare and difficult cancers to improve research-based care, create a national care guidelines that currently don't assist the TERI. And along with the tour board, we've also stood up the Department of Defense Cancer Clearinghouse. I've included a copy of a handout of that for you in your packets. This site allows any military care eligible patient or military provider to submit a request for information, or a physician may request a second opinion, or they may refer a patient for continued specialty care. And these requests come right to my NOACs, so I can route them to the correct provider team, or if it's appropriate, I will answer those questions directly. Our response time has been less than 24 hours, and usually it's just a few hours or less, which have an amazing turnaround. The feedback I've received is that they're appreciative to be able to speak to a person who is familiar with military patients' unique needs as a cancer patient. And it's our hope that we can use the site and make it more increasingly utilized across the DoD.
It's very good to not know that was there. Very good. Well,
I think as we near the end, I'll just make a few comments, and then now I'll turn it over to Nina for closing remarks. First of all, thank you everybody who's joined on the live stream. Thank you to the 5 of you. I think, and the DoD, all the agencies who do these community conversations, we really took to heart the community part. You're the community, you're the patients. You represent many other thousands across the Department of Defense and loved ones who are experiencing the same thing you have. So thank you for your courage and your honesty. Those are the 2 words that I wrote down here that came to mind as you were talking. Courage and honesty. And I think, thank you, ma'am, for your willingness on behalf of DoD senior leadership and health affairs to listen to these courageous and honest people and the support you've always provided us at Mirtha, and everybody down in your shop. I really appreciate it. I'm just proud of the conversation that's gone on today. I'd like to thank the Biden Cancer Moonshot and the White House Cancer Moonshot team who really supported us and helped put this together. And then finally, the Uniformed Services University, which is the Department of Defense's America's Medical School, who've really supported all of this today, all the live streaming, and put all this together through the Vice President for External Affairs, Glenn Deal, in his office. So thank you to your SU family. Let me turn it over to you for final comments.
So I'm going to echo what Dr. Schreier said. Thank you so much for sharing your stories today, which are very, very hard to hear. Everybody, as there's probably nobody in this room doesn't know anybody else who hasn't been family members and touched by cancer. It's all of us. It is. We always thought by now we would have, canceled cancer, and that's not happened. And so now we just need to find better ways. I've heard a lot today. If Dr. Charver and I were talking, we're going to hear what we've captured here, and I promise to take back and put some of the challenges we could do. Some may be easy, others are hard, and it's like you said, it's always a budget issue for some things. But we'll see what we can do on some of the policy sides and extending that. And I've been very proud to be a part of this administration that's pushed forward some of the things that have occurred in the last few years too, to make some of your lives a little bit easier going forward. So thank you again for coming out and coming all the way here. Thank you for everybody wants what you have here. I mean, if we had a little magic checkbook would replicate everybody on this side of the table at every place across the country at every single MTF, so we could have the excellent thing for everyone to have this availability. So thank you all very much for today.
Thank you.
Appreciate it. Thank you.